Transplantation in the early 70s was in Nashville. Everything was done there. Early on, when there were only one or two transplants, those transplants just came over to the VA hospital, had their laboratory work done there when they came back to clinic visits, and then went over to Vanderbilt to get their to see their doctor and be checked over. Also, the histocompatibility on the donors were done still at the VA hospital, and any histocompatibility testing that, of course, needed to be done on the potential recipients, even though those recipients were at Vanderbilt. Well, all this was going fine until one day a patient came over to the VA hospital, and this woman had a transplant, and she was walking across the parking lot under a barrier, one of these arms. I don't know what those things are actually called. Well, as luck would have it, it was up, and she walked under it, and at that particular point in time, the barrier decided to come down, which it did, and struck her shoulder and knocked her down. It was at that point in time pointed out that she was not a veteran, yet she was being taken care of on a compassionate basis at the VA hospital, and people started asking questions what was going on, and then she just said she was a transplant recipient and was over at the VA hospital getting laboratory work done. Well, this started a series of questions in higher levels, and the word was very quickly sent to the transplant program that this had to stop, that the VA hospital could not continue to do laboratory work on non-veterans. It was a VA hospital. How do we do this? And the decision was made, and fortunately, by that time, the dialysis unit was functioning in a way that earned income over expenses, because Medicare had taken over responsibility for funding the program in the private sector. So that we had a certain amount of money, and we decided we would take the step to set up a histocompatibility laboratory to handle the private patients. And we also wanted to have some control over the laboratory, so it was clear that the focus of the laboratory was to support this particular group of patients. We, of course, got referrals from all over the state. The number of transplants increased. The number of patients being worked up for transplant, hence getting their histocompatibility work done, also increased, so that the work of the histo laboratory became a lot greater as the patient population increased there. And of course, the clinical laboratory also increased in its activity as well, both for post-transplant patients, but mostly for maintenance of the dialysis patients. You know, we're getting more and more dialysis patients. Perhaps this would be a good time to set up our own clinical laboratory to provide laboratory work, the routine labs which we get on our dialysis patients on a monthly basis, or more frequently as they needed it. And that's really how the laboratory was instituted.
Our lab has 24/7 call, and we receive typing materials from the donor, and we certainly have in mind that the work that we're doing is helping our patients, because we follow patients. You know, we get their blood in every month, we check their antibody levels and such, and so we may not have a face to the name, but we know the name.
Now, over time, the laboratory evolved. As DCI expanded, the clinical laboratory really expanded. When the transplant program, when Dr. Ritchie took over the directorship of the renal transplant program at Vanderbilt, the numbers of transplants really exploded.
You know, they need somebody to help them with doing the kidney transplants until I can recruit a transplant surgeon. I said, okay. He said, didn't you work with Dr. Zukowski? I said, yes, sir. I said, he said, you know, you're a vascular surgeon, and vascular anastomosis, you can do that. and the urologist will do the bladder anastomosis. I said, okay, I'm glad to help out. And that's when I began to work with Dr. Johnson. I said, I don't know a lot about immunosuppression. You know a lot about that. I'll do the transplant, you do the immunosuppression. I won't do immunosuppression if you don't do transplants. And so we sort of bonded right then. And the VA, of course, had a dialysis program, and they were doing transplants and the VA because it was funded. And there was not any funding for the people at Vanderbilt unless they had, private funding of their own. The only patient I can recall that had private funding was a guy named Felton Jarvis, who was the manager of Elvis Presley. And as I recall, Elvis funded his transplant. I think when I started doing them, there had been exactly 100 done at Vanderbilt. And I think the first year I did 55, 54, something like that.
Of course, transplantation then became very much available at Vanderbilt as the number of patients who then were being dialyzed gradually increased. And that's really kind of the story of the laboratory. It really handles 99% of the work that it does is for the internal support of the DCI clinical activities and those things that DCI does related to transplantation, mainly histocompatibility, except the histo laboratory now performs histocompatibility testing for all the transplant programs in the state of Tennessee, including Memphis, Knoxville, Chattanooga, and of course the two programs in Nashville at Vanderbilt and at St. Thomas.
Well, currently we are a full-service dialysis laboratory. We specialize in the ESRD population, take care of our 15,000-ish patients in 29 different states. We run all of their monthly composites, the chemistry profiles, CBCs, PTHs. We also test all of the water labs, cultures and endotoxins for the technical department and the dialysis centers.
I think the lab today is sort of more in a progressive spot. We have a lot of opportunity to continue to improve. We do a great service for the clinics. We provide lab testing that is very specific to the needs of our nephrologists and our dialysis patients. But kind of in a going forward position, we are just looking to streamline what we do, similar to clinics and anybody in healthcare today, so that we can better utilize our resources to best meet the needs of our clinics and our patients alike.
I think we all feel that we're actually very connected to the patients. We know their names. We live and die by their results. We see them before their transplant, during their transplant, and after their transplant. So I think we all feel, despite perhaps not personally knowing the patients, but I think we all feel very connected to the patients we serve.
The whole story has been a sort of a matter of doing things because we needed a solution to get the job done, and this was the way to accomplish it. And it has worked out exceedingly well over the years.